and welcome. I hope that you can all hear me. If you can't hear me, please just raise your hand. I would like to welcome you to our 6th installment of the webinar series that we are hosting from down here in the tip of the African continent. Thank you for making this time to be here, and really believe it's going to be a fantastic time of engagement and reflection. We probably all are getting used to the realization that nothing ever seems to work normally. We are almost in a permanent and a persistent state of emergency, really. And even as we think we are slowly coming out of the COVID-19 space, we are probably already thinking about what lies around the corner. And I think it's for this reason that this seminar is quite important, where we can look back, where we can look forward, where we can learn from each other, consolidate and reflect in this space as citizens of this great continent in which we live. I'm going to just ask Chantel to put the program up as I welcome you. You will notice that apart from presentations that will be made, there will be chance of sharing experiences, there will be discussion, and also we'll kind of reflect back on the activities that are meant to support the work we do with respect to immunization on the African continent. So with these few words, I just want to say welcome to all of you. Welcome to this wonderful time that we're going to have together. And I just want to thank the niche team for working quite hard behind the scenes of putting this together, as well as all our speakers and discussants who have made themselves available to enrich this experience. Just a few things to note is that you will be able to have access as an attendant to the question and answer space, where you can use that. You can see the Q&A in the bottom, where you can actually write comments and as well as questions. And I probably should have said this first. If you look at next to the hand sign in the bottom of your screen, you will also see that kind of globe sign that shows you that there is interpretation, where you can just click on that and choose the language that you understand, that you can partake fully in the whole proceedings of this meeting. I think with those few words, welcome to our 6th webinar installment, conducting routine immunizations during public health emergencies. And thank you again for making yourself available. With that, I will hand back to the next speaker.
Good morning, good afternoon. My name is Aisha Kadir. I'm a pediatrician, and I am a senior humanitarian health advisor for Save the Children. Just bear with me, and I will go ahead and share my screen, share my slides. And if you can, let me know when you can see my screen. Whoops. All right, can everyone hear me?
Thank you.
Excellent.
Perfect.
All right, great. Yeah, good morning, good afternoon. So today, thank you for inviting me to join you today. This is an honor and a privilege. We have about 20 minutes to talk through trends in public health emergencies across the continent. And I think the most useful way, I was thinking about the best way to shape this talk to kind of lay the stage for the rest of the presentations and discussions. And I think the best way to do it will be to break down the presentation into basically covering the trends in the drivers of public health emergencies across the continent, and actually think about, we'll review what this means for children. So before I do that, I would just like to really quickly tell you what this picture is. This is a photo from southern Somalia from May this year. After a few years of failed rains, there was some very heavy rains in May and flooding, which displaced more than almost 220,000 people. More than half of them were children. And it not only displaced people, but it also destroyed homes and health clinics and schools and shops and livelihoods, and of course interrupted access to primary healthcare and routine healthcare, not the least of which was immunization. And we'll actually come back again to what's happening in the Horn of Africa as one example. So this sort of this photo, I think, is quite a stark image when we look at how much of the area was underwater. But what, just looking at the continent, thinking about the entire continent, I'd just like to point you to, if you're not already familiar with this, the WHO Health Emergencies Program actually has a website where they have a global map. This is an image from Africa, but actually I'm going to click on the link. There's a hyperlink, which we can share with you. I'll share it with you in the chat. And you can actually see the whole world. There are some notable gaps, I should say. We won't go through how health emergency is defined, but rather what we can do is kind of focus on what kinds of health emergencies have been identified across Africa. And so you can zoom in. So if I just click the little plus sign and I zoom in, I can kind of choose. The more you zoom in, the more detail you can see. So that's kind of helpful. And if we can take a look at, for example, DRC, Democratic Republic of Congo. If we click on the circle is really, it indicates the intensity of emergencies. And then for each circle, when you click on it, basically a little panel shows up on the left side of the screen. And it will note some of the emergencies. And again, just keep a grain of salt because it doesn't note all of the emergencies. And while this was updated not very long ago, you will see some that are missing. But the key point here is if we start to look at these different, what are listed as these emergencies, you see cholera, measles, polio, vaccine-associated polio, armed conflict, go to Nigeria, cholera, diphtheria, Lassa fever, Mpox, vaccine-associated polio, conflict, yellow fever. We go to, Liberia, Lassa fever, measles, Mpox. Let's go to Somalia. Adverse effects of viral vaccines. I think this is COVID. And then cholera, drought, flooding, measles. Interestingly, conflict is not there. Sudan, conflict in 2021. We know there's a conflict going on right now as well. Cholera, civil unrest, dengue, diphtheria, measles, Rift Valley fever. And you go on and on. Look at Chad, measles, vaccine-associated polio, Mozambique, cholera, polio, vaccine-associated polio, and in 2022, wild-type imported polio. Botswana, COVID, Zimbabwe, cholera, Malawi, cholera, COVID, imported wild-type polio. So I think everyone will get the point here now. There's a lot of there are trends, we can say, in the kinds of emergencies that have been identified as public health emergencies, and they really center around armed conflict, forced displacement, climate change, and outbreaks. And when we think about sort of all the different ways that public health emergencies can impact children, there's this, so we have this kind of this is oversimplified, I should stress, but we have this intersection between armed conflict and climate change. They interact. Certainly climate change and extreme weather events can cause or exacerbate conflict, certainly can also change the nature. They both can lead to displacement. Displacement can lead to armed conflict, and of course can impact the local environment. So the three are sort of a vicious cycle in influencing each other and influencing how the situation is in any given local area. But very importantly, there are some pervasive effects that happened that manifest in children, and especially in young children, on their health and their development. And so the bit on the right is a very busy diagram from a paper from a few years back that was really trying to unpack how extreme weather-driven disasters can influence child health. And they were looking at not only the flood or the storm or the cyclone or some other weather disaster. What they're also thinking about is all of the other things that happen when an emergency happens and how that also influences children's health. And so you have these internal stressors. So you have, risk factors on the right that are red, and you have resilience factors on the left and in the blue color. And I mean, it's worthwhile. I can share the paper if that helps. It's worthwhile when you have a quiet moment to just have a little time to study this in more detail and think about it, because I think it applies to the whole population, but this is actually fundamentally important when we think about children's public health and how disasters can impact them. Or adversity can impact them, because it's pervasive. So you see these external stressors can be things like, the built environment. It can also be things like earthquakes or landslides or armed conflict, displacement, changes in social arrangements, which then impacts, whether a child can go to school or whether a child gets married, whether a child then becomes pregnant and becomes a parent as well. Also violence, multiple forms of violence, interpersonal violence that children may experience. There's also disruption of health, public health infrastructure, sort of disruption of supply chains to health facilities, health workers who are forced to flee. And then there are ecosystem impacts around water, sanitation, and hygiene that get impacted. Obviously, we are here to talk about immunization and routine immunization in these contexts, but there's also changes in the local environment that can make, for example, certain vectors or certain, they can increase the risk of and the likelihood of communicable disease, whether it's humans coming into more close contact with animals that they don't normally or have not previously had contact with, like zoonoses, but also people being crowded together and living closer together, not having access to their basic needs. And this all leads to things like pneumonia and diarrhea and polio, for example, as well, measles, various forms of pneumonia, not just pneumococcal, but other forms as well, rotavirus, Haemophilus, we can go on. All these vaccines that we have that prevent diseases are increased. These diseases are increased in these, or the risk of them are increased in any form of disaster. And then there are protective factors. And on the left side, the protective factors are, of course, there are big things like, changes in the way we live to mitigate climate effects, which is not just relevant for Africa, but also relevant for the entire world, especially the global north. But also things like making sure that we have buffers in place to counteract the effects of temperature rise, or places for people to go if flooding happens, or robust public health systems with really good routine immunization, access to primary services, access to acute services, prevention as far as we can, and making sure people have access to treatment. And then, of course, there's also the family and social factors to try and reduce impacts of the stress on the whole family and how that influences children. And the key to this, I think, in the middle, in the black is, you see that, so child health is at the top. And you can see that there's actually a huge psychological component and there's a stress physiology component. So what happens is when children experience multiple forms of severe adversity, the effect is cumulative. Every additional adversity has an additional impact, and it has measurable harmful outcomes on children's bodies and their all of their organ systems and their brains. So the perception of stress, the stress response, also how parents and children or caregivers and children interact. This can be stressful or it can be protective, depending on how it goes. And parents need to be able to understand that. So immunization, when people come in for their routine care, is actually a good opportunity to link in with other aspects of primary care to protect children. So I think we sort of talked about this. I'll go very quickly through it. But in terms of climate, the climate crisis impacts are getting worse. We're seeing, and on the next slide, I'll talk about El Nino for this year, but we're seeing that it's forcing people to move to survive or to have some hope for their future. People are leaving where they are, whether they're pushed to or whether they decide to is almost not relevant in a way. The point is that people are moving, and children are also moving unaccompanied. People don't necessarily move with their vaccination cards, so we don't necessarily have records of how many immunizations they've had, how fully immunized children are. They're also, when they move, they end up very often in having periods or perhaps extended periods without adequate access to their basic needs like water, sanitation, hygiene, adequate space. So overcrowding is an issue. Many people are moving to urban areas. They often find themselves in slums, and they're more vulnerable than the rest of the population to extreme weather events. And so it's this vicious cycle. This, just very quickly, is a graph of the predictions for how El Nino will impact the globe this year. And Africa's right in the middle on these maps. The top row is the expected or the forecasted rainfall, and the bottom row, where the red is the temperature that's expected. And what you can see is there are parts of Africa where there's expected to be high or extremely high rainfall coming up in October, November, December, and also maybe letting up a little bit in January, February, March. So we are now heading into an area where we expect to have more and more rain. It's going to be wetter. And that wetness will continue through March, but especially over the rest of 2023. At the same time, heat is going to be a major issue, is expected to be a major issue. In the bottom row, you see the darker the red, the more heat there is expected. And so again, on the left, you've got October, November, December of this year. There are quite a significant proportion of the continent is expected to be experiencing very extreme heat. And that is actually expected to worsen when the rains let up a little bit in January, February, March. So we can expect with that worsening water, sanitation, hygiene conditions. Mosquito and other vectors will probably be increased. People will be coming into contact with them. People will be suffering in this, but there are things we can do. Again, immunization being the fundamental, I think, cornerstone of child public health, to try and mitigate against that. And lastly, before we move on to some examples, I just wanted to talk about all of the social factors. So armed conflict was one of the drivers of public health emergencies that we saw in that WHO map. The map talked about droughts. In some places, it mentioned droughts or flooding, and then conflict or post-conflict or political instability. And then it specifically identified a number of specific communicable disease outbreaks. And that was that's the lens with which the WHO emergency public health emergency program looks at public health emergencies. I would like to take a pediatric perspective about public health emergencies and think about how all of the changes, whether it's from climate or from armed conflict can impact the life of a child or a community of children. So we very much focus, you can see these two big forms of violence, interpersonal violence, that's whether it's domestic or in the community, or at the subnational or national or international level, you have sort of armed conflict. These are what we really often think about when we think about violence, and that increases whenever there's a public health emergency. Certainly interpersonal and community violence becomes more prevalent. Sexual violence becomes more prevalent as well. This happens everywhere in the world. And the violence, children are not only witnessing it, but they're subjected to it as well. But equally important are these, just up on the right of the screen, you see these arrows. They're perpetuating, there's this social arrangements that are unfair or inequitable. Structural violence that is basically the way our society is organized, the structures of our society, which actually harm children and promote or compound these other forms of violence and economic violence. These all have measurable impacts on children's health and well-being, and they certainly play a role in reducing access to primary care services, and immunization being a fundamental part of that. So globally, this is a child survival crisis. We've got more than 5 million children dying every year before they reach the age of 5. 80% of these children are in Africa and Asia. And while immunization has actually improved a bit in Africa compared with the rest of the world, there are still 12.7 million children who were under-vaccinated across the continent in 2021. And there are almost 9 million who've never had a single dose of a vaccine. And the lack of routine catch-up immunization schedules means that many of these children will never be vaccinated outside of a campaign unless we start to develop routine catch-up immunization. And so when we think about things like measles and polio, diphtheria, these are diseases that we don't develop immunity to unless we get the disease. And so they need a catch-up immunization. It's not just, rotavirus is only indicated for the early years of childhood because it reduces severe diarrhea and it reduces mortality. But there are a number of other vaccines that we really do need to catch children up for their own health and for the health of the population in general, to reduce the impact of all of these compounded public health emergencies, to reduce the risk of outbreaks, for example. So related to that, really important point is that 12 million children are acutely malnourished across the continent. The stunting prevalence is almost 31%, which is well above the global average. And then we don't know what this is doing to the rest of their bodies and their development, and how that impacts whether or not they go to school and how they can move around in their communities, the age at which they're likely to be married, or if they marry, and if they have children, what age and how does that happen, and what does this mean for their life outcomes? All of this, it starts at birth, really, and it starts with these influences on health, of these factors that impact their health. And vaccinations, routine vaccinations, have a compounded protective effect. So if you vaccinate a child for example, with PCV, the pneumonia vaccine, what we find is that it doesn't only protect children from streptococcal pneumonia or invasive streptococcal disease, so meningitis or sepsis, but it actually reduces the risk of malnutrition, because it prevents them from getting it basically, the fewer infections a child has, the better their health is. And malnutrition, severe and acute malnutrition especially, it's not just an issue of lack of access to food, it's compounded with recurrent infections. So if we can vaccinate these children, then we can actually reduce the rates of malnutrition. And crises, they have really pervasive impacts on child public health. So we really shouldn't be waiting for an emergency to be declared. I think in places where there isn't an emergency, we have a window of opportunity to try and reduce the likelihood of outbreaks and communicable diseases. So I realize I'm about to run out of time. So I'm just going to quickly take us through 2 examples to make it more concrete. And I think my colleagues in the subsequent presentations will also give much more in-depth discussion about specific contexts, and then we can have a discussion about what does this mean when we are trying to implement routine vaccination, the essential program on immunization. How do we do this when there's an emergency? There are adaptations, and we have some lessons that we've learned. But first things first. So Somalia here, we see the Horn of Africa, but especially Somalia on this map. On the right, you can see the food insecurity, the IPC phase classification. You see the darker the color, the more severe. Basically, we have a pocket here of the highest, the worst is red. It's probably a little difficult to see on your screens, but then there's a lot of orange and yellow also in Kenya. And Ethiopia, while it's gray here, there's definitely impacts. This is a mix again of the climate impacts and political instability and armed conflict and forced displacement. We've had one of the worst droughts this year in decades. This has been compounded by the conflict and instability, compounded by COVID, compounded by geopolitics. The war in Ukraine is impacting grain exports through the rest of the world, and this is having a very, very palpable impact across the continent. People are forced to leave their homes to look for, basically for their livelihoods and pasture for their animals, but food and water. And they are experiencing worsened water hygiene and sanitation conditions. There are high rates of acute malnutrition, which we expect with food insecurity. There's also a low vaccination coverage. So it's a perfect storm for outbreaks. And we are seeing this, right? There's currently there's a focus on measles and cholera and malaria and pneumonia and strengthening sort of disease surveillance as well, and as an outbreak response. But there's a real there's a risk of this, and we're sort of doing our best to try and mitigate through things like campaigns, as well as, of course, nutrition response. In Sudan, on the 15th of April, an armed conflict, a civil war effectively has erupted, and there are almost 5.5 million people who've been displaced. Just under half of them are children, and about half of them have fled to neighboring countries. So people are moving to Chad, Egypt, South Sudan, Central African Republic, Ethiopia, and Libya. And this is a mix of returnees, so people who had fled their home country and then return to their country of origin, and also Sudanese refugees who are fleeing to these countries. Health workers and their families are very heavily affected by this. Many of them have fled or been displaced also internally. And there are attacks on health facilities. So the public health infrastructure and the health infrastructure is directly affected and targeted by combating parties. The conflict is shifting, it's dynamic, populations are moving, and it's very difficult humanitarian access because of this. So an example is in Darfur, there's a very limited functioning of health facilities, but health services are delivered through static facilities and through mobile clinics. So when you have disrupted supply chains, and when you have people moving around, and you have attacks on healthcare and health workers fleeing, then the health system struggles to function, right? And we also have a limited sort of interrupted surveillance mechanisms to understand where are the risks and what are vaccination coverage, for example, and where should we do a campaign to try and prevent an outbreak. What has happened is exactly what you expect. We now have cholera and dengue outbreaks that have just been identified. So there are both cholera and dengue in Gedaref state, and there's dengue in Gezira and malaria in North Darfur. So immunization is, again, a really key component of the response for outbreak response, but it's also something we can do, especially if we can try and maintain good immunization coverage and good uptake of immunization, trust in the system as well, then we're much more likely to reduce these kinds of outbreaks in the face of multiple other stressors. So it is, crises are increasingly protracted. There are disparities. So even within a country where it's experiencing crisis, if you have a stable area of the country and a peaceful area, you see differences. In immunization coverage, you see differences in all aspects of their health and their social outcomes, especially in children. And there's this intersection between different stressors, including vaccine preventable diseases. And so our solutions really need to focus on maintaining routine preventive access to care for preventive care and treatment services in spite of crises. And the gaps in immunization coverage will require routine catch-up schedules to meaningfully improve the immunization coverage. Thank you so much for your attention.
Thank you so much, Ayesha, for that excellent talk. We're going to proceed with the next talk by Mesret. And Ayesha, if you can stay with us during the discussion session, that will be great. And also to the participant, if you've got a question, comment, please just type on chat as we wait for the discussion session. Over to you, Mesret, and thank you so much.
Thank you, Ben. Can you see? Please confirm if you see my slides.
Yes, we can see your slides. Just put on the presenter view mode. Thank you.
All right. Sorry. Okay, just a second.
Perfect.
Okay, thank you. Is it okay?
Yeah. Yes, perfect.
Okay,
perfect.
Colleagues, good afternoon, good morning. My name is Meseret. I'm working for the World Health Organization as a part of the inter-country support team with the Vaccine Preventable Disease Unit. And I'll take you on the challenges and opportunities in providing routine immunization services during emergencies, conflicts, and within humanitarian context. So the two guidelines that you see on the left and right will be shared with you. On the left is the framework for decision-making when we are in acute humanitarian emergencies, and also an implementation guide, which is how to do vaccination in humanitarian emergencies. So now, focusing on the challenges, the lack of access to vaccination services in acute or protracted conflicts and humanitarian emergencies represents an important and growing reason for stagnating vaccination coverage. And the delivery of immunization services in such setting presents many challenges. And I think my colleague already, Aisha, has alluded to the fact that what we're seeing increased number of outbreaks recently is, of course, effect of the pandemic, the decreased vaccination levels that we had for years. In some countries, we have stagnated for years. Insufficient coordination within the public and private sectors for some countries, inadequate engagement of the national immunization programs during this humanitarian context, lack of surveillance and laboratory capacity, definitely a part of the system limitation. So inability to link epidemiologic and lab data, mostly we really look at suspected cases. And then the ecological factors, which I have alluded to so many of them. However, I want to highlight opportunities. Our audience mainly being NITAG members. We are looking at NITAGs having increasing role in providing recommendations on vaccines and strategies to be used during emergency and even in humanitarian response. We would like to really allude that if this could be linked to the incident management system that WHO promotes in member states whenever we face acute emergencies, that is established to coordinate the emergencies, where NITAG's input can be incorporated specifically if there is a need for emergency vaccinations. And many countries have done it. For example, Ethiopia, I'm sure during the COVID pandemic has guided for the measles campaign. So the NITAG advice is valued, and as it is evidence-based, and NITAGs should anticipate more requests in updating either immunization policy guideline or technical guideline whenever it is required during emergency. And what we have learned also, and what we allude, is we should use existing clusters on ground for service delivery. We shouldn't reinvent the wheel. There could be existing already touch points like the food and nutrition distributions. It brings efficiency. So highlighting the challenges and opportunities, I'll move into the principles, really, the background. In the humanitarian emergencies, I will not read through all, but because you'll get the slides at your leisure time to enjoy them, I'll just highlight the key issues here. So the humanitarian crisis of short duration, long-standing crisis and conflicts could result in protracted humanitarian emergencies. So the concept of acute emergency does not imply that emergency in itself is short-lived. Mostly they start as acute and they could result in protracted crisis. However, even in protracted crisis, situations can emerge and be considered as acute within that crisis. The second point is emergencies may lead to major and possibly continuous disruption of vaccination services provided through the primary health care, with resulting in drop in vaccination coverage. A very good example is the pandemic, if you recall. So the consequences could be a decrease in population immunity, and that is the main reason we are seeing in increased morbidity and mortality from vaccine preventable diseases, with the risks for huge outbreaks. So in emergency situation, we should recognize especially children and women as vulnerable communities, a part of the community, and they are always more predisposed to the communicable diseases outbreaks. So I think my colleague has alluded to the facts, to the risk factors increase. So let's pass it there. Vaccination should be among the high priority health interventions implemented during these emergencies to limit the avoidable morbidity and mortality from vaccine preventable diseases. So here we are to maintain or to re-establish strong routine vaccination services as primary objectives. So this is one of the backgrounds I would like to share with you. Acute emergency, occurrence of one or more of the following conditions due to any reason. It could be natural and man-made, and I think Aisha has alluded already. Sudden unplanned displacement of a large population could be from their habitual residence, the direct exposure after civilian non-combatant population to new or exacerbated conditions, impending or already occurred sudden deterioration of nutritional status. Look at the Great Horn with huge or immense droughts this time. The natural or industrial disaster could also happen, resulting in temporary homelessness and disruption to critical public services. For example, here, do you recall the flood, the exacerbating flood in Malawi, and also cyclone in Madagascar? Sudden breakdown of critical administrative and management functions within the public and or private sector, especially exacerbated during conflicts or in humanitarian situation. So this could really exacerbate, and these are the conditions where these could result. So what actions are we expected to take? Our guideline says to establish a task force, and specifically an immunization task force is required, or equivalent if you have a technical working group. But it has to take the role of the immunization task force. So in humanitarian emergencies, it's very critical to clearly identify and appoint the team to lead and coordinate the immunization activities. The task force should be established by the highest level of health authority, like during the COVID pandemic that we had. And this task force may be established in the country based on existing bodies to avoid creating parallel systems. If you have it, let's use what you have. But it should consist of government and local authorities and partners, such as national authorities, international NGOs, organizations, civil society organizations, to be overall part of health task force so that decisions could be really involving all stakeholders. And the host country or government and or local authorities should have the primary responsibility for directing and coordinating the operations. And one of the main strengths of the immunization task force should be the mechanism for evidence-based decision-making that all members should adopt, advocate, and apply. That's where now the NITAGs would really help the technical working group of immunization in the countries during these emergencies. Now, the roles are clearly outlined. I'll not go through them in detail, but the functionality should be guided by terms of reference in emergency settings. You can see representation of all levels of administration, orientation of a sort of in the control room operations should be really to coordinate the activities, communications streamlined, and ongoing response to the needs in the periphery, including the media. So immunization task force and health cluster interaction should be aligned. And the national level focus for the task force should be policy issues and strategic planning, while at subnational level, it guides the local planning and implementation, just sharing. So early involvement of the community in all aspects of the immunization work. And then the task force and NITAG should work together on technical issues. So functionality of the task force needs these elements to be considered for its successful operationalizations. Usually NITAGs are missed out, and we would like to really reinforce the NITAG's role during this emergency humanitarian crisis. The second is to promote the decision on use of vaccine in humanitarian emergencies to be evidence-based. This will help us determine what emergency vaccines to deploy, what are the specific target populations, and the relevant geographic locations guided by the evidence. So the NITAG will look at the disease characteristics. They will look at the target beneficiary population, including the service delivery characteristics, which should be tailor-made for the specific geographic context. Material resources, that is health facility infrastructure, and when we don't have it, we can even approach it through the mobile teams or mobile healthcare service. So these are the actions where we want them to be really evidence-based guided decision. Now, the guideline that I already showed you on the left was the framework for decision-making promotes the risk grading of vaccine preventable disease assessed in identified regions, provinces, or districts. So on the left, it promotes the level of risk due to factors specific to the targeted vaccine preventable disease. For example, measles. Is it high, the risk? Is it medium? Is it low? And that it will be guided by the level of coverage, by the population immunity, etc. On the right side, you could see the level of risk due to other general factors that they would consider to be categorized high, medium, or low. So there are added guidelines that will show you immediately. So if it is high, definitely to consider. If it is medium, you may be also more possibly to consider, or even do not consider in certain areas, while in certain areas, it will be of high category. It's just a snapshot that we are showing you how you come to decide on this level. So there is a worksheet to determine the presence of key general risk factors. For example, high prevalence of malnutrition. Many effects on vaccine preventable diseases like measles will be exacerbated. There will be increased deaths due to measles in severely malnourished children. Young population and or high birth rate, where we have that in many of our countries, there will be greater pool of susceptibles for vaccine preventable diseases. So it is this worksheet really helps the NITAGs to go line by line with the risk factors, with the main effect of the considered vaccine preventable disease, and they will ask the question and possible indicators to grade the risk as medium, high, or low. And then, in addition, relevance of each general risk factor for each primarily taught vaccine preventable disease would be seen. For example, you can see my red arrow is showing if it is measles. If there is high prevalence of malnutrition, you can see the relevance would be very high. Young population and or high birth rate in the next column, again for measles, it is high. If there is high burden of HIV, so I will not go through all, but just to promote the tool that the NITAGs can use. the previous one, and the relevance of each targeted vaccine preventable disease during these acute emergencies. Now, there are also specific factors to be assessed for each vaccine preventable diseases: the population immunity, the burden of disease, the geography, climate, and season also. Seasonality for specifically for measles, influenza, and so on, or like you have seen. So there is also additional algorithm in the decision-making framework for the qualitatively synthesizing the vaccine preventable disease specific worksheets that the NITAGs could use into an overall grading of specifics risk. So does the setting of the humanitarian emergency and prevailing environmental conditions potentially allow for transmission of the vaccine preventable diseases? If it is no, the grade is overall risk of low. But if it is yes, what's the risk level associated with population immunity? If it is medium to high, to the right, you can go, what is the risk level associated with this burden of disease based on pre-emergency data or any reports since the emergency? If it is medium, look at how we are going to grade overall specific risk as moderate. If to the right, if it is very high, we will grade overall specific risk as high, unless one or more of the other factors, including population immunity, considerably can mitigate the risk. So there is even a final algorithm after the tools are used by the NITAGs to come out with overall grading of the specific risk for any of the vaccine preventable diseases. Now, there are also vaccination implementation consideration to help the NITAGs. It should be evidence-based. What is the target age group that is really concerned? What is the estimated number of people targeted? Are host communities to be included? Are the people stable and well-defined in a camp setting, or is it highly unstable where we are expecting continued migration or displacements? What should be the timing? Where should be the geographic areas? What strategy should we use? Can we access them through the fixed sites, mobile positions, or a mix of them? What was the required logistics? What can we do for demand generation, really? Here we have to understand the behavior of the community. Monitoring, evaluation, and informed consent, sometimes we have to. So all this should be evidence-based. So for the strategies, these are the key questions that the NITAG should ask. So on the decision on the use of vaccines in humanitarian emergencies, we have to look at the logistics capabilities, the human resources, the financial resources that are estimated, the social context of the community, not only the hosts as receiving community, but also of those displaced who have come to this side. What are the local challenges at the lower level? And then, as a principle, can we integrate so that we create efficiency of health service delivery in these humanitarian emergencies, especially in vaccination during humanitarian emergencies? So these are sort of decision points that we have to look at in detail. The components of the emergency response vaccination plan will have these as basis: a micro plan where we list the individuals, the targeted communities, we map them, we calculate them. We should know the age, gender, the geographic areas, and their characteristics, really. So if we develop it from the lower level, then it can come up to a national plan as a response plan. But this will guide the budgeting as an operational plan. So once we know who they are, how many they are, what are the age groups, then we can estimate the vaccine supply. We should think of bundling of supplies. Demand related, we should know the behavior social drivers, including community-based interventions. Then tailor-made strategies, accessibility to guide the strategies. Should we do quick in and out? Should we use transient points? Should we have staggered vaccination points? All those would be looking in under the specific strategies. But we should continuously monitor, evaluate, and also provide supportive supervision. Innovative methods have really simplified this. And in many of our countries, real-time data is becoming accessible these days during emergencies as well. However, at the end, we have to have exit strategy for the recovery of routine immunization, from shifting from the crisis during emergency to rehabilitation transition, And then this should be incorporated into the annual plan, into the multi-year plan, so that it is also budgeted for. So these are the components of the emergency response vaccination plan that we need in humanitarian settings. For each of them, there are detailed steps, and we have included them. We have hidden them. We will not show them now, but you can refer to them later on. And the suggested strategies for service delivery, I'm just showing it as a guide. For specific contexts during different emergency situations for vaccination, to guide the NITAG are there. The context, if the area is in active conflict, what operational strategies? If it is a natural disaster, what should we use? If it is for internally displaced or refugees, what are the strategies we should consider? So these are already part of the framework of the decision-making guide. My colleague has highlighted, but I would like to show you some observed situations in the region, because this is real. The setback in immunization and emergency-related conditions I'm going to show you. On the left, you see the diphtheria outbreak, the AP curve, up to week 14 only. Sorry, it's not updated. However, you can see thousands of suspected diphtheria cases reported in Nigeria, of whom 39% were confirmed, with case fatality rate of 13%. Please, audience, look at this. Will this not happen in our setting? Is it because we don't have the confirmatory tests in each of our labs? Should we not be considered with the decline of routine immunization that we have, especially with the huge number of zero doses that we have in our sub-region? So that's one, because of the setback. But emergency-related also, there is outbreak. You can, my colleague has showed it, but we have to enhance the readiness, heightening surveillance, scaling up health education. We are not vaccinating against cholera routinely, but definitely there is an opportunity for the cholera vaccine also as preventive, where we know the risk factor is high, or during the crisis also. So a one dose provides protection up to 6 months, this oral cholera vaccine. Single dose effectiveness among above 1 year old was up to 40% against cholera episodes and 63% against severely dehydrated episodes. Why I brought both is it's not only looking at the routine immunization, but there could be diseases where vaccination applies during emergencies. Just as example, you can see the measles incidence rate per million and large and disruptive outbreaks. For your information, on the right side is when a country has over 20 cases per million population, then the countries listed on the right are having large and disruptive measles outbreak. So that's what we use in the WHO's definition. You can see our many countries already in Africa, so and also Asia. This is just another highlighter, measles being an indicator. So for few points in summary, NITAGs have increasing role in providing recommendations on vaccines and strategies used during emergency. And the key actions should be evidence-guided to decide on what strategy to be used and what timeline to respect. And in emergency, you may be called upon on ad hoc basis, but we have tools and guidelines and will be with you to guide each NITAG accordingly. But so far also, they have really produced output, which we'll hear from the countries. So I don't know about, so I have put so many slides, Ben, and this is my last. I will stop sharing my slides. So I don't know if I have overstepped the time. Over to you, Ben. Thank you.
Excellent. Thank you so much, Mesret, for the wonderful talk. And we're going to share the slides with the participants. I hope it's okay to share the extra slides that you did not get the chance to present. Excellent. So Mesret, stay with us so that we can engage during the discussion session. And we're now going to move to the next speaker, who is Leah, Ethiopian NITAG, who is going to share with us the experience of Ethiopian NITAGs in making recommendations on vaccinating during public health emergencies. Leah, over to you, and thank you.
Thank you very much for inviting me to give this brief presentation on the Ethiopian NITAG. My name is Leah, and I'm an immunologist by training and based in a research facility in Ethiopia. And I am presenting this on behalf of the Ethiopian NITAG. I hope you are seeing my slides, right?
Right, Leah. Thank you.
Thank you. So, in this brief session, instead of giving a briefing on the NITAG's activity, I opted to give you a few highlights on the Ethiopian immunization activities challenge, and finally highlighting the NITAG's role in this. So just to give you a context of the Ethiopian, which is in the Horn of the Africa, with over 120 million population, ranking 11th globally, has also more than 80% of the population are rural residents, and the proportion of females and males is fairly similar, and the current birth rate or fertility rate is around 4, with a median age of the population is about 19 years, and the children under 1 year are about 3.1%, and the children under 5 years are about 15%. This is in fact based on the 2017 data. I couldn't find the latest data available. Again, immunization is one of the basic health services in the country. As the previous speakers also mentioned, Ethiopia has over close to 400 hospitals, around 3,000 hospitals are health facilities are health centers, and 18,000 around 18,000 are health postes. Out of this, more than 20,000 health facilities are providing immunization services to the population nationally. And according to the Ethiopian DHS, under 5 mortality rate has declined from 123 in 2005 to 59 in 2019. And on the right side of the slide, you would see the current vaccination coverage for all EPI vaccines. And in this slide, I tried to present the last doses of the vaccines, like the oral polio vaccination, BCG, PCV, and the pentavalent vaccine, measles and Rota. And according to the WHO immunization data portal, the immunization coverage for the last doses of the polio vaccine is, like, for example, 64%, BCG 68% during the pandemic period, PCV around 61%, the pentavalent vaccine, the last dose around 68%, and measles 56%, and second booster dose of the measles vaccination, in fact, was recently introduced, and around 48%, and the Rota around 65%. And if you consider immunization services during different conditions, particularly in the public health emergencies, pandemic situations, and one of the challenges has been health service disruptions, so precluding routine immunization. And most unit facilities and personnel during, especially in the pandemic, in the COVID pandemic, have been diverted to curb the pandemic, and so the immunization facilities have been shifted. Their activities have been shifted to the pandemic services. So the immunization has been disrupted for some time. And recent studies also published in one of the regions of the country that around 62.2% of the children who have been delivered in a health facility did not complete their immunization. And in the same report, they also indicated that most of these children, around 85% of them, took BCG vaccination and oral polio vaccination, for example. So the second or the last doses of the vaccination have been disrupted, which occurred during the pandemic conditions. And if you see the pentavalent vaccination or the PCV, for example, the immunization drops out were significant. It declined from 84% to 72% for pentavalent vaccine, and from 84 to 74% for PCV vaccination during the pandemic situation. And most of the major factors that attributed to this decline in the dropout of the immunization were like poor maternal health literacy and economic condition, the poor service seeking conditions, and because most of the mothers were also have been taking transportation vehicles to allow their kids for vaccination, they had this fear of acquiring or catching the COVID during transportation, and so this dropout were attributed to such conditions. And the long waiting time at health facilities, and most of this EPI vaccine facilities being also being also utilized for delivering COVID-19 vaccine has also been reported to be one of the attributing factors for the immunization dropouts during the pandemic conditions. And other challenge for better immunization services in the Ethiopian context were also one of which is also access to the proven or new vaccines. And COVID has provided a good example where most countries also had this vaccine nationalization, where access to approved vaccine was also difficult. And for other vaccines, even expensive cost and financing needs and the global supply chain constraints have been also considered as some of the challenge to reach out to the vaccination needs in the society or in the community. The other issues that have been highlighted as challenges are like hesitancies and resistance for new vaccinations. And as the previous speakers also mentioned, internal displacements and humanitarian crisis due to conflicts also contributed significantly as a challenge for better immunization services being provided to the community. And poor vaccination coverage in some settings like pastoralist or semi-pastoralist communities has been also one of the challenges for better immunization services. The catch-up vaccination services, in fact, has been recently introduced, and implementation and the integration into the implementation of the catch-up vaccination services has been also a problem in the past. But of course, this has been recently introduced into the immunization services and is improving. The other problem is infrastructure challenge, where the cold chain facilities for vaccine placement have been a challenge and or lacking in most health facilities. And the weak surveillance system, be it in terms of data for lack of data digitization or delays in reporting and the quality of the data, the staff turnover, estimation of actual disease burdens, poor regulatory frameworks to estimate or track severe or adverse events, and overall poor research landscape to track better understanding of herd immunity or generate implementation research outcomes, or infrastructure and lab capacity has been also indicated as a challenge. So what is Ethiopian NITAG's role in this challenge? So of course, is to advise the immunization services to introduce new COVID vaccination, for example, and also efforts to make routine immunization such as measles vaccination campaigns during the ongoing pandemic condition, and continually also advise the ministry to on issues like on vaccine delivery using other alternatives such as chartered airport or airplane, or use of mobile team service delivery through humanitarian organizations like WHO or other civil society organizations, and also development of catch-up vaccination guides and implementation of targeted catch-up vaccination services in areas with intensive interruptions. Some of the opportunities I highlight, this is my last slide, is for better immunization is, of course, as Dr. Massarat also indicated, the role of NITACs and their presence in the health system is something crucial and important, and that needs to be continuous in providing evidence-based decision making, and their presence and continued advisory role can be considered as one of the opportunities. And the national or regional awakening of self-sufficiency in vaccine manufacturing, especially this is something that COVID also have brought up because of the vaccine nationalization, and several factors around that have affected or awakened the health institutions and health systems to have self-sufficiency in vaccine manufacturing. So there has been some progress in strong political commitment to ensure this is in place in the near future, and support also from African CDC and WHO and other organizations has been also considered as an opportunity. And capacity building and strengthening for lab infrastructure is also something that the immunization services could be better up in the coming years. I will end up my presentation here, and we'll take up questions later if there are. Thank you for listening.
Thank you so much, Leah, for sharing the experience of Ethiopian NITAC, and I'm sure there will be questions. Please type your question on the Q&A chat box, and Leah is going to be with us during the discussion session. So the questions that you're not able to type, we're going to speak to them during the discussion session. Now we're going to ask Betty from South Sudan, NITAC, to share the experience of South Sudan. Betty, over to you. And thank you.
Good afternoon, everyone. I hope you can see my slides.
Betty, we can see your slide. It's now showing future direction.
Now it's showing the beginning, I hope. Yeah.
Yes, to the South Sudan context. Is that the slide you want to be speaking to? Yeah, there we go.
Okay.
Great.
All right. So, good afternoon once again. Thank you very much for inviting us. I'm going to share with you the South Sudan experiences and lessons in conducting routine immunizations during public health emergencies. Now, I'm going to give you a quick presentation. First of all, we're going to start routine immunization in South Sudan, then the South Sudan context and the contextual effects on routine immunization. Then we'll look at the coverage in South Sudan, including the challenges and opportunities, the role of NITAC and its experiences, lessons learned, and the future. And please feel free. All right. So on routine immunization in South Sudan, one thing that I like to bring to light is that the main target group for vaccine country is children from 0 to 11 months and kind of reproductive age, that is 15 to 10. Only exceptions to this is the non-vaccinated children who are 12 to 23 months. When we get the opportunity to buy such age groups, we usually provide all that actually shows the vaccines that we use during routine immunization and the dosage. And the general is that one of the vaccines include next year, inshallah, and this one is not going to be at the national level because we plan to start small and roll out. So it's going to be started at the sub-national level, and it's going to cover all children who are less than years. And the other exception is the COVID-19 vaccine, which is only for children or adults 18 years and above. Tetanus toxoid and diphtheria vaccine, which is for all the children and only females from 15 to 49 years old. Otherwise, all the other vaccines is for everybody, and the coverage is on a national level. Now, coming to the South Sudan context, I think it's common knowledge that
we seem to have lost Betty. I think most of you could hear that there was disruption in a presentation. Betty, are you there? Are you back?
I think it's internet connectivity. So let me try to reconnect and share. Am I back?
Yes, you're back. You're back.
The internet is not stable. That's one of our challenges, actually.
Okay, we understand. Thanks.
Okay. So, so what I was saying earlier is that South Sudan is actually a country that's exposed to lots of humanitarian emergencies, which are either the result of or can result into displacement, overcrowding, which ultimately lead to food insecurity. And then the end result is overcrowding. And some of the precipitating factors we have here is the natural disasters. And probably most of you already know that like last year or a few years back, the northern parts of the country are actually flooded. Like people are literally living underwater. And the exact opposite happened in some of these states in the southern parts of the country where there's drought. And this can all lead to food insecurity. And the other problem is the man-made emergencies. And we are all aware that we have one of the longest civil wars in the country. And there are still pockets of insecurity here and there all over the country. But one of the commonest is the intercommunal fights, which are for several reasons. And this often lead to loss of livelihoods as people are displaced. And then not forgetting the complex emergencies that are happening. And one of them, as had already been mentioned by previous presenters, is the conflict in Sudan, which is actually leading to influx of refugees into the country. And we also do have pockets of outbreaks here and there, not forgetting the recent COVID-19 pandemic. Now, all these emergencies actually kind of like impact on the health sector, leading to limited access to basic health services. And there's often resulting destruction or closure of health facilities, especially when there's insecurity. And sometimes there's temporary or total breakdown of health facilities. Now, what comes out of that? This actually results into an overwhelmed health sector as people or huge populations are displaced from one area to another, thus resulting into public health emergencies. And with that, we have often had increase in water and vector-borne diseases like diarrhea, cholera, typhoid, malaria, and many other diseases. And there's also an increase in vaccine preventable diseases. I think we've had lots of outbreaks like measles outbreaks, and there's malnutrition and its complications, and there's mental health issues that are often the result of the loss of livelihoods. Now, how do all this impact immunization? One is that when the populations get displaced, there's often limited access to the needy populations because they have moved. And even if they want to access services, it's not possible because already what is existing has been destroyed and there's no way to access that. And another effect is that on vaccine supply chains, and this often results from the infrastructural damage needed, or what is existing has already been damaged. And another important aspect is the community hesitancy, because of misinformation, mistrust, and fear. So it becomes really very difficult when vaccinators have to, when they are trying to access certain communities, and those communities tend to view them as enemies. That's all because of mistrust. And then the source constraints scale of immunization, lack of civil documentation and registration, which actually hinders planning, not forgetting the dropouts, also the fact that the vaccinators have a range and have to, of course, hostile conflicts in order to access the regulations. So things get very difficult. However, the surprise is that in spite of all those difficulties, the routine immunization check into the WHO release estimates of the national immunization coverage. Here, starting from 2011 to 2022, you can actually see that by last year, on average, our vaccine coverage is about 72%, which I think is not that bad. So probably the question that comes up is, how did we manage? Now, in every situation, there's always challenges, but in spite of those challenges, there are opportunities. So one of the ways that we have been able to really manage this problem is the investment in human resources. And that is human resource training to ensure capacity is available to provide the services that are needed. And the second thing that we have invested in is ensuring a continuous supply of vaccines to sustain immunization. Like, we just have to make sure, use our estimates, do our quantification, procure the vaccine, and push them out there. And the third aspect is the risk communication and community engagement, especially through the gatekeepers. And this is actually meant to address the mistrust, suspicions, and rumors that can negatively impact vaccine confidence, and also to create awareness on the health needs and risks, especially when it comes to vaccine preventable diseases. And these gatekeepers, actually, the one here are the chiefs, and they are a community that we can lay our hands to, somebody who can take decisions and the community can listen to them. These are people that we make use of. And last but not the least is the integrated outreach activities. Often these are joint activities that are organized and then are meant to address needs during windows of access. So whenever it's possible, such displaced communities, there's actually these outreach clinics that people go there, provide the services within the windows of access, and then they get out of there. And these integrated outreach activities also help in addressing the resource constraints, because it's not like one program going out there, it's 2 or more programs. So we kind of like consolidate whatever resources are available, and this actually helps address one of the resource constraints that we often face during such activities. Now, the role of the NITAC. We are all aware that the NITAC is a technical advisory body, and there's more functions related to implementation, coordination, or regulation of immunizations. And the only thing that we can logically do is to provide evidence-based recommendations, guidance, and advice on policy. So what have we been doing all along? Like the roles I've cited here, actually generic roles that each and every NITEC is supposed to be doing. So on the role of providing recommendations for introduction of authorized vaccines, I think we're doing very well on that one. And as you have seen on the previous slide, we have actually lots of like a considerable number of vaccines that are actually included in our routine vaccines, and there are some more that we're lobbying to include in the coming few years. So we're good on this one. So coming to review and revision of existing NITAC recommendations, also we're good on this. In fact, one of the things we're considering reviewing is the use of the measles containing vaccine, the measles only vaccine, because I think there are reports of outbreaks of rubella in some parts of the country, and we're actually thinking that's something that we can change to an MMR vaccine, but these are things that are under discussion. And on the area of cooperation and exchange of information with independent expert committees on immunization of other countries and international NITEC networks, I think us being part of this webinar is actually part of this responsibility, and we will also continue to explore more opportunities where we can be able to share our experiences and also gain experiences from other countries that are living in contexts that are more or less like our own, so that we can benefit from their experiences as well. So it's an ongoing thing. Now, on cooperation with international organizations providing support to the immunization program, we're actually good on this one because we have a very, very close working relationship with the major partners in country, including the World Health Organization and UNICEF and GSI and many other organizations like Save the Children. Literally, most of the organizations at the central level who are involved in immunization activities. So we're good on that one. But that doesn't actually stop us from exploring or exploring links with other organizations that are working in the country. It's an ongoing thing. Now, on the issue of strategies and new directions in immunization policy, as well as the monitoring of immunization program and surveillance, and that of adverse events following immunizations, I think these three areas we are still not spot on, because as a new body, like the current members actually new off, and they only started the activities somewhere around mid this year. So we are still in the process of working on our work plans and monitoring and evaluation plans, including surveillance plans and research agenda. So once we set those things in place, I think we'll be able to like invest more and engage on gathering of evidence, information from the field to guide the decisions. And also we will be able to like take action whenever any adverse events are recorded. So that's something that we're working on. So the lessons learned in our experiences, this is a crowded slide, but I'll try to take you slowly and not in any particular order. So one thing that we have learned is that when working in a complex situation, you have to be adaptable and also be flexible. And this is really, really paramount. And on top of that, one of the things that you need to really do is that you have to understand the political context and be able to place yourself strategically so that you are able to achieve your purpose of giving vaccines to children in order to minimize the vaccine preventable diseases or prevent them actually. So as I said earlier, the ability to adapt swiftly to changing circumstances is really, really critical, because as things happen, they really happen very fast, and you have to be able to adapt as fast or even faster. And flexibility is also paramount. Like when you have some decisions have to be taken very, very quickly, and this is very important. Is usually when things that happen, so you have to really be on track with that. Really made use of that is when we were able to very quickly switch from AstraZeneca, which requires 2 doses, to Johnson & Johnson vaccine during the COVID-19 epidemic, because it came to our realization that when you give them the first dose and then things start happening, they move out of that location to another location, and then it becomes difficult really to access these people. And that leads to high levels of vaccine dropout. So we thought like actually giving them 1 dose will address the situation, and we're able to very quickly adapt to that. The second thing here is collaboration. And I'll stress again that collaboration is key in everything that you're doing when you're working in a complex environment, because effective collaboration with the humanitarian is very, very important, because it can actually facilitate your work, and also the coordinated efforts maximize resources and minimize duplication of services. And data-driven decision-making is key. That literally means that you need to invest in getting real-time data and analysis. And these are indispensable for informed decision-making. And not only that, but the identification of coverage gaps and disease outbreaks in areas needing immediate attention are actually entirely dependent on data. So it's worthwhile to invest in the data. And is also very, very important, because it not only ensures a continuous building for healthcare workers, which actually enables them to respond effectively to immunization challenges during emergencies, but it also caters for turnover and attrition. Because we're all aware that when somebody is subjected to a lot of work, a lot of pressure, after some time, they actually kind of wear down, and even if they're high-performing people, their performance actually drops. So giving them refresher trainings here and there actually helps to rejuvenate them. And also it caters for the turnover, in that usually when the situation is not stable, people tend to move and look for greener pastures. So you have to make sure that as they move out, there are new people moving in, and they also have the necessary skills in order to continue providing the needed services. So that's very, very important, and you can only achieve that through continuous health worker training. And the other aspect is the advocacy for resources. It's actually important to secure funding and resources for sustaining immunization programs, because one of the challenges is that whenever there are emergencies or crises happening, there's always like the resources are usually not enough, because the demand is very high. So keeping aloof and ensuring that continuous resource mobilization is there actually helps to address some of the needs, so that the program is not forgotten. And also continuous engagement with stakeholders to ensure adequate support. We had to always keep talking to stakeholders. That way they're well informed, and they're able to support wherever possible. And last but not the least is the cold chain requirements. Link with the emergencies is that sometimes things get destroyed, as I mentioned earlier, and it's not only the infrastructure in the medicines and that facility that may get destroyed, but also the cold chain equipment and the vaccines can get destroyed when things go wrong. So one of the most important aspects is that adaptation to existing cold chain equipment and requirements for introduction of new vaccines is vital for increasing the cold chain capacity in the country. Like generally what we're saying here is that we have to make use of the available resources, make the best use of them. And one example is the use of the same cold chain storage requirements for both the AstraZeneca and JJ vaccines, because both actually have to be stored under temperatures of 2 to 8 degrees centigrade. Now, looking at the future direction, One thing that in immunization programs, and the focus here should be on enhancing the ability to adapt to various emergencies. This is really, really important, although it's a very difficult thing, because most of the time, resilience is something that's intrinsic. It involves a lot of soft skills, something that really is difficult to train somebody on. But despite the fact that it's a little bit tricky, we still advise that it's good to encourage the people involved to be more resilient, like to always stand up where they've fallen down and continue with whatever they're doing. This is very, very important for continuation of services. And the second thing is improve surveillance and data systems. Investment in robust surveillance and data systems is actually very crucial for the early detection of outbreaks and monitoring program performance. This is something that needs to happen. We do have surveillance systems in the country, but we really hope that they can be improved on. And we shouldn't also forget that while we're working on the improvements, it's usually good to make use of every single available data source within the country, because it's very, very helpful. The other aspect is the use of innovation and technology to improve services delivery and data collection. One thing that probably might need to be looked at on a very serious note is the use of mobile health apps, especially for data collection. And we also know that in other countries, these mobile apps have been tried for interactive telemedicine, where doctors and patients communicate in kind of a long distance manner. But those have their own challenges. And I think the easiest we can go for is to use that for data collection. And another aspect that has also been tried somewhere, and we think it's something that's worth looking on, is the use of position data from SIM cards. These have been used in other countries, and I think it's something worth trying to use for estimating the magnitude and trends of population movements, especially where these movements are they happen anywhere and anytime. It's something worth trying out, as well as the use of phone data to track locations of individuals where there is network coverage. And then the other thing also that we're thinking of is the sustainable funding mechanism. This is really...
Sorry, Betty.
Hello?
Betty, how many more minutes? Because we're running out.
Am I lost again?
Can you hear me, Betty?
No, I'm actually done. This is the last slide.
Okay, great.
I'm hearing you loud and clear. Are you getting me? This is the last slide, actually.
Yes.
Hello? Yeah. Yeah. So the other thing is also advocating for sustainable funding mechanisms. And then capacity building is continuous, and that's something we need to invest on. And then the continuous learning and adaptation, especially for the NITEC members, this is also very, very important. And then last but not the least is strengthening the local partnerships. This is something that's already happening, but it's something that has to be continued as long as emergencies are still existing. And I think with that, I end here. Otherwise, thank you very much for your attention.
Brilliant. Thank you so much, Betty, and to all our four speakers, Dr. Ayesha, Dr. Mesrat, and Dr. Leah, and also Dr. Betty. We appreciate. We've got fewer minutes for the discussion session than we planned, but you know, we don't have any comment or question. I think Louise has posted a chat to you, Betty. You can have a look. But if somebody wants to ask a question or make a comment, please raise your hand. And Salim, if you could give them the right to speak. I see a hand from who? Did somebody raise your hand? And Salim is going to Sidi. Go ahead.
Thank you, Ben, and thanks for all the facilitators' presentation. So this very, very good and very focused on the immunization, so emergency. Maybe I will switch to French. So if you can, OK. Je pense que Betty a touché du doigt un point essentiel, à savoir l'adaptabilité des groupes techniques consultatifs durant des situations d'urgence sanitaire. Adaptabilité en termes d'organisation des réunions, parce que les réunions le nombre de réunions va augmenter. Ça veut dire que le GTCV va avoir besoin de plus de ressources pour organiser ces réunions, mais aussi adaptabilité en termes d'expertise. Donc, le GTCV aura besoin réellement d'avoir une nouvelle expertise. Dans certains pays, je pense que l'Ouganda est là. Ils ont dû faire appel à des éthicistes, donc par rapport aux recommandations des vaccins comme les nouveaux vaccins contre la COVID. Donc ça c'est quelque chose qui est très important, mais aussi adaptabilité en termes de révision des procédures opératoires normalisées du GTCV. Et je pense que la COVID-19 nous a tous surpris. La plupart des GTCV n'avaient pas ces politiques en place. Et c'est le temps quand même entre les épidémies ou les pandémies de pouvoir réviser vos procédures opératoires normalisées pour inclure en cas de situations d'urgence sanitaire, qu'est-ce que le GTCV va faire et comment il sera organisé. L'autre, c'est par rapport à la prise de décision basée sur les données probantes. On a vu durant la COVID qu'il y avait beaucoup de pression politique, mais aussi de pression des uns et des autres parties prenantes de la vaccination. Et il est important que le GTCV puisse garder ce cap-là en se basant sur les cadres de recommandation qu'ils ont déjà au niveau de leur procédure, manuel de procédure interne, et rester focus sur ces cadres de recommandation-là pour pouvoir produire des notes de recommandation qui sont dénuées de toute pression de la part des parties prenantes de la vaccination. Merci. Over to you, Ben. Thanks.
Thanks, Sidi, for that comment. And Betty, just to let you know, there is interpretation service. If you go on the bottom of your screen, you'll see that globe icon with interpretation. If you click on English channel, when a French-speaking person is making a comment, you're going to hear the translation in English. Pawelas,
okay.
do you want to go ahead? So before you go ahead, I think thanks, Sidi, for that comment, because you also raised an issue that I was discussing with Mesrit on the side, that the public health emergencies and humanitarian crisis not only affect the immunization, but can also affect the work of NITAGs. And you've clearly articulated that and given the example of other NITAGs, including the need for more resources, which is absolutely critical. Right, Pawelas, Besha, your hand is up. Do you want to go ahead?
Okay, thank you so much. First and foremost, let me acknowledge and appreciate all presenters for great presentation they have made. My name is Dr. Paulos. I'm a specialist family physician working in Swatini, South Africa. I have two questions. One is maybe goes to Aisha or Meseret, and the second one maybe goes to Leah. So let me start from the first one. The first one is regarding the composition of NITAG members. So what should look like the composition of members in NITAG members? Because I think the composition of the NITAG members determines the effectiveness of the work. So in some countries, maybe the composition may not have public health people, or maybe they can be just clinicians. So which might compromise the effectiveness of the work. So what is your take, or what is your advice regarding the composition of NITAG members where there are shortage of different disciplines? The second one is, I think goes to Leah. I saw in her presentation that the measles vaccination was very low, so it was about 56%. And as far as my knowledge is concerned, measles vaccination is one of the old and the senior vaccination, and I was expecting to be on the higher side, but I was a bit surprised to see it being 56. So what could be the reason? I understand there are some factors that contributed to vaccinations, but I couldn't understand why, especially measles, is so low in Ethiopia. Thank you so much. Hello?
Do you want me to go first, or is it the first question was, I thought, for Dr. Meseret?
Leah, you can go first, and
Yeah,
Meseret can come second. Is that okay?
Sure.
Yeah.
Yeah. Thank you for that question, Dr. Paulos. In fact, I am a researcher based on a research facility, and so I don't really have a concrete data on the actual immunization coverage of each vaccination. And the data I presented here is entirely derived from a WHO immunization data portal. But I can assume that the data I showed is just from the year in the pandemic time, like in 2022, where there was a pandemic issue and also internal conflict and displacement, where there has been also reports of measles outbreak. But in fact, from the audience, I noted some of the people from the immunization unit in the Ethiopian Ministry of Health are also participating in this conference, and that they can reflect on the actual scenario, maybe on the chat box, that might help. I don't know if I address your question, but this is what I can say. Thank you. Over to you.
Thanks, Leah. And then, Meseret, maybe you can give an answer to the composition of NITAGs, and also a chart that I've seen on the link between NITAG and RITAG.
Okay.
Meseret?
Okay, thanks, Dr. Paulos, really, for your interesting questions. The composition of NITAG, the National Immunization Technical Advisory Groups, you know, they have advisory functions, they should be independent, and they have to guide us in with evidence-based methods. So there are expertise that we require, minimum from 7 to 10 to 15. So we need infectious disease specialists, pediatricians, internists. We need, if possible, logisticians for the logistics aspect. We need neurologists. There is also a need for pharmacologists, immunologists. So I think we have the list which we can, if you put down your email, maybe we can share with you the document so that you are very much aware of. So these are selected by the government. They are mostly, they come from academics, but also they are practitioners in their own setting to guide. But public health experts, epidemiologists, they are always part of the core group. This is the core members. But then we have the ex officio members, which we call ex officio, are the government. Like, for example, there is a regulatory function in each government. So vaccine regulation, from that unit, we need representation. From the surveillance epidemiology of the government system, we need representation. So they are like ex officio, parastatal or government, but they really complement the NITAG work. Then we have also liaison officers. They are agents, people coming from WHO, UNICEF at the country level. They are liaison members. So we usually have from, on average, from 12 to 15, and in some countries up to 20 membership. But definitely public health expertise and epidemiology is a core, infectious disease, and so on. So this is what I would say. But if you put down your email in the chat, maybe we can give you some more background information for you. And the fact on measles, I think if the Ethiopian team is not responding, I think Dr. Ria used the WHO UNICEF estimate, and to explain the basics, governments have reported coverage, administrative coverage that they provide. But from time to time, they do coverage surveys, either through the demographic health survey, which includes immunization, or EPI-specific survey, WHO-recommended survey. Then that result is approximated with the administrative coverage, and the WHO UNICEF usually comes in between. So that is the estimated coverage. And usually it is close to reliable than the administrative reports that we get. When you see high coverage reporting countries and they are having every 2 years or every 1 year and 6 months, huge outbreaks, definitely, most of the time from the outbreak studies that we did, the reason was no vaccination, period. And many countries say, oh, it could be cold chain failure and so on. Yes, it contributes, but basically around across the countries where we studied, the reason was no vaccination. So I just wanted to highlight that. And we have progressed beyond coverage. We are actually looking at absolute number of children that we are monitoring. So I don't know if you can put your email on the chat, we can forward to you some of the documents. Over, I don't want to take all the time, Ben.
No, thanks, Mesrat. And I think the other question, Pawelos, is going to be answered on chat because you're running out of time. Chantal, will you present briefly on updates of the niche activities so that we can quickly go to closure? So if you've got a question, please type on the chat, and we're going to address your questions as the presentation by Chantal goes on. Thank you. Over to you, Chantal.
You just give me a second.
Sure.
Okay, so I'll just give a brief update on some of the activities from the NITAG Support Hub project, that's niche. And just a quick, the first update is on the annual vaccinology training for NITAGs. This is an annual event that we hold each year. It's by invitation. What we do is we don't invite individual NITAG members, but we invite the NITAG of the country to come as a group. And the selection and invitations are done in collaboration with WHO, AFRO. And so we had our first annual vaccinology course for NITAGs in July last year, and our second course, July this year. And so far we've trained 20 countries, 20 NITAGs were trained. During this course, it's a 5-day course, and the focus is on vaccinology, and it's designed specifically for NITAG members. Of course, we have our webinar series, and this is our 6th webinar, but just to let you know, and we'll put this in the chat so that you can get the link. We have the previous webinar recordings on our website. So we've had 5 webinars so far. The first one was on challenges and opportunities for COVID-19 vaccines rollout in Africa. Second was COVID vaccine acceptance in Africa. Third, adverse events following immunization with COVID-19 vaccines. The fourth was emerging evidence on the efficacy and effectiveness of single-dose HPV vaccine and its implications for WHO Africa region. And earlier this year, we had webinar 5, malaria vaccine introduction in Africa. And we will be putting up the recording of this webinar on our website as well by the end of the week. We've also hosted what we call research stays. This was the first time we've hosted a research stays this year. This is an opportunity for individual NITAG members to spend a month in Cape Town at the University of Cape Town with a niche project. And the aim is to provide NITAG members with mentorship and opportunities to strengthen and expand these skills in vaccinology and evidence-informed decision-making. And this is based on an application process. Next year, we will be advertising on our website again, and as well as through WHO, through other partners, and directly we would share the application forms and directions with the different secretariats and chairs of the NITAG as well. And via the application process, we hosted 2 NITAGs, one from Ghana, one from Cameroon. And they spent a month with us in July. In terms of the program, they were able to join us for the annual vaccinology course, which was at the beginning of July. And thereafter, we had a program where they spent some time with various niche team members. And during those sessions, they were exposed to and discussed vaccinology and epidemiology principles, conducting evidence searches, critical appraisal of research articles, and addressing local data gaps. They also had sessions with UCT consultants that work with a niche project in health economics and modeling, health systems and design thinking. They were able to spend a week with Cochrane SA, one of our partners, looking specifically at how to conduct rapid reviews. They also had a session with Task Force for Global Health on the E2R framework and online modules, as well as with GNN Secretariat to look at what are the GNN resources available. Then I just wanted to also highlight that we have a number of assets and resources that is on our website, and it's under assets and resources. For NITAGs, we've developed 4 library guides thus far. These are guides that provide published peer review and grade literature on a specific topic. And we have 4 of these guides on our website: COVID-19 vaccine confidence in Africa, malaria vaccine in Africa, HPV, and interventions to promote routine vaccine coverage. And we're going to pop this link in the chat as well, so that you can, if you want to go and have a look at these, please do. It's on our website, as I said, under assets and resources. Then we also have 2 evidence gap maps that we've developed. These are interactive visual tools that provides an overview of research evidence in a particular topic. And so we have developed one on COVID-19 vaccine confidence in Africa and another on strategies to improve vaccine coverage. Again, we'll pop this into the chat, and please go have a look and interact with those resources. Just to give you an update on what we have in the pipeline for the next 6 months, just briefly, we do have 1 more webinar scheduled for this year in November, and we'll send out those details and have that up on our website as well shortly. And the first one will be on novel polio vaccine. Early next year, we'll look at Hep B birth dose. We will also reach out to understand from you, what are the topics that you would like us to focus on in terms of webinars going forward. We will have online courses available, and this will be through our website where you can register on a learning management platform. And these courses will be uploading these within the next year, between October and November. So do keep a lookout for that, but we'll send out communication as well. And so that will be in evidence informed decision making, as well as modules on epidemiology and immunology. And these modules are very specific to the needs of NITAG members in terms of those topics. We have an upcoming training in collaboration with WHO and Task Force for Global Health on E2R and vaccinology in Ethiopia in December. It will be a group various NITAGs coming together as a group, and they'll be trained during that time. We are also setting up a working group with WHO and Task Force for Global Health, as well as other partners, to look at developing a theory of change, which is an overarching theory of change, showing what is the support in the Africa region to strengthen NITAGs, and that will help in terms of ongoing monitoring and evaluation. Also wanted to just let you know about the technical services that are available through Niche. Again, you'll find that on our website. But what we have is, in terms of, this is basically a free service, because we have UCT-based consultants who are available. If NITAG members require any of these services in mathematical modeling, health system strengthening or design thinking, health economics, when they are looking at developing policy recommendations. We also have a service in terms of providing rapid evidence synthesis, and we have, evidence-informed EIDM specialists within our team that could support. So how do you access that? Just to let you know, there are various channels that you can access if you are interested in any of these services. One, we have a help desk on our website, and again, we'll just pop that into the chat. But you can also directly email us on our email niche@uct.ac.za. We'll pop that into the email, and just correct that for me, Salim, who's popping this into the email. It's niche@uct.ac.za. But you can also request services via WHO and speak to Sadi, and because we do collaborate with WHO when we're providing these services. Thank you. Over to you, Ben.
Thank you so much, Chantel, for showing some of the work that Niche is doing in collaboration with partners, and specifically WHO. We appreciate that. Please, you know how you can reach to the Niche project team. We've got an email, we've got a website that you can go to and reach out to us through help desk, or even speaking through to CD and Niche work very collaboratively, or even Louise at WHO HQ, and also with Gerard, who is on this call at WHO EMRO. And for now, I think we're just going to end. But just before we end, a couple of thanks to the 4 speakers. Dr. Ayesha, who has unfortunately had to drop early to go to catch a flight. And to Dr. Meseret, not only for speaking during this webinar today, but also, working with us to actually prepare for this webinar. Much appreciated, Dr. Meseret. And Dr. Leah and Dr. Betty for agreeing to share your experience. That's wonderful. And, it is the richness, the richness of this webinar is by NITAGs actually sharing their experiences, because that's the essence of this webinar, where NITAGs can learn from each other. So we very much appreciate. And in our next webinar, we're going to reach out to other NITAGs to share their experience. If you feel as a NITAG, you've got some experience you want to share with us in our next webinar, please feel free to reach out to us. And finally, to the Niche project team, thank you very much for making this work, and very happy to be working with you, and wishing everybody a wonderful day, afternoon, and see you again in the future. Thank you so much, and bye-bye, everyone. Thank you.
Thank you so much. Bye-bye.
Bye-bye.
Thank you, Ben. I think it went well. Sorry for rushing through my session.
No, it went well. It went very well. Thank you so much.
Thank you. Yes.